तर काय करतो इनिशियली कंपनीला इंट्रोड्यूस करतो, तुम्हाला इंट्रोड्यूस करतो अँड आय स्टार्ट द स्लाइड्स. देन यू कॅन
Oh,
शेअर
that's
युअर
great.
एक्सपिरियन्स.
We are on live, so we are good to go now.
या चालू करतो सर. Hello, doctors. Good evening and welcome to this experience sharing program on managing PPH, case studies from labor room. This program is brought to you by Hetero Healthcare. Hetero Healthcare, is an innovative pharmaceutical company. We have 25 years of excellence and 36 state-of-art manufacturing facilities. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries. 21,000 employees globally, and Hetero Healthcare is the largest closely held pharmaceutical company in India. Hetero Healthcare is amongst the largest manufacturers of ARV, APIs, and FDFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which, in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, Experience Sharing Program on Managing PPH, we have got Honorable Speaker Dr. Sudesh Doshi with us. Welcome, sir. Welcome to this webinar. Dr. Sudesh Doshi is MBBS DGO LLB, Senior Obstetrician and Medical Legal Consultant. Sir is working since 28 years in rural setup at Agraj Hospital, Pandharpur, Maharashtra. Chairperson Adolescent Health Committee 2016 to 18, Medical Legal Committee 2020-22, AMOGS, Member NIMC, PCP NDT, FOXY, President Pandharpur Obstetric Society, Vice President IMLEA, Maharashtra Chapter, Member EMLC FOXY, State Coordinator AMOGS. With this brief introduction, I'll hand over the session to Dr. Sudesh Doshi. Over to you, sir.
Thank you, Dr. Prashant, for that kind introduction. Now, I suppose my audience is hearing me well, and my audience includes all the medical
Yes, sir. Yes,
people
sir.
from
Yes, sir.
various
Yes,
medical
sir. We can hear you well.
faculties.
Yes.
Yeah. So, as we know, we all obstetricians, we always have a nightmare when it is a PPH, and we always pray that there should be no PPH in my practice. But unfortunately, it's not like that. If you say that I have never faced a PPH, then maybe you are not delivered a patient at all. It would be like that. So we will first go through our postpartum hemorrhage. Postpartum hemorrhage, as we all know, by definition, we have studied the textbooks, 500 ml or more of blood loss during vaginal delivery, or 1,000 or more blood loss during cesarean section. And though it is defined as 500 ml, 1,000 ml, we all know that the loss is always underestimated. It is very difficult to precisely calculate the amount of blood loss. So we have another definitions like patient's blood pressure going down, of fall of hemoglobin of more than 1 gram per cent, and so on. But we know that when we have seen so many number of patients delivering vaginal during cesarean section, we can sense, our sixth sense tells that no, this is patient is having PPH. This amount of blood loss is much more. And we know that PPH is common and causes one of the most common causes of maternal death, which is a very unfortunate event for anyone, and it's a stigma to the country itself. So, unfortunately, at common, maternal mortality is leading cause of accounting to 35% of maternal deaths. Maternal mortality in developing countries was 240. Now we are coming down. Now I think the last statistics was that all over India we are coming down to less than 100. In Maharashtra, it was somewhere around 30. So, because of the combined efforts and joint efforts of all gynecologists, all the anesthetists, then all blood banks, the good roads, government setups, that every 30 kilometers you have a facility to do a cesarean section and to deliver a patient. Blood banks are more, products are available. And because of that, our mortality ratio is coming down, but still it is very high. Global PPH incidence, we know 14 million women suffer from PPH. Incidence around 2 to 4% after vaginal delivery and 6% after cesarean section. Now, PPH incidence in India, The references which are given, they said 38% are maternal deaths are due to PPH, and 25% of global deaths take place in India, and two-thirds of them are attributed to PPH. The India has an unexpectedly high maternal mortality death rate of 5 foot. Now that is a wrong statistics. I would like the people to correct it. This was long time ago, somewhere around 1990 or 2000. Now India has got a maternal mortality death rate of around maybe 100 or less than that. I don't know the exact figure, 1995, something like that. Next figure, please.
We'll correct it, sir.
No, please correct it. Etiology of postpartum hemorrhage, again going to old textbooks, our teachers have told us it is stone, tissue, trauma, or thrombin. Most times it is stone. The uterus simply refuses to retract, and then we have to diagnose it and treat it in time. So when the inability of uterus to contract, which may lead to continuous bleeding, then thrombing, the patient is of severe PIH, gone into DIC, there is coagulopathy and failure clotting that is going to cause tremendous amount of hemorrhage. Trauma, either uterine trauma or vaginal trauma or cervical tears. We know difficult vaginal deliveries, previous LSCS deliveries, trauma to the vaginal wall hematomas, cervical tears causing bleeding, cervical tears extending into the parametrium, broad ligament hematomas, and injury causing this trauma may cause bleeding. And tissue, yeah, this has been well known that if there is some retained placenta or placental bits are retained, members are retained, it may cause either primary or secondary hemorrhage. So we all know the causes. Next, please. So clinical findings in PPH. Now there is a table showing what are the degree of shock in PPH. We know that diagnosing PPH and then diagnosing the amount of blood loss and degree of shock is a methodology which we all know, and we follow the algorithms taught to us. There is abdominal tenderness. Now, abdominal tenderness may be a finding in PPH in case of traumatic PPH or scar tenderness. Otherwise, in atonic PPH, abdominal tenderness may not be there. There is circulatory collapse. The patient's BP falls down. The pulse is not palpable or pulse may be thready. There is increased abdominal girth in cases of when there is a intra-abdominal hemorrhage, then you may get increased abdominal girth. Loss of uterine contractions you can see, and maternal tachycardia and vaginal bleeding. Maybe the green ones are for the uterine rupture scar signs, scar adhesion signs. They have combined with this. So clinical findings, we know that there is mild, moderate, or severe shock when the amount of blood loss is more, and there is compensation. But the pressure change is not much in mild shock. So when there is almost 1,205 ml of blood loss, then only blood pressure starts falling down. And signs and symptoms vary according to, say, palpitations, dizziness, tachycardia, weakness, sweating, and maybe collapse in air hunger in the severe cases. So we know there are different indices to measure the degree of shock. One of them is in this algorithm. Other is there is a shock index where they say if the blood pressure is less than 100 and if the pulse is beyond 100, then the patient is in shock. So the tachycardia, pulse rate beyond 100 and blood pressure less than 100. Next, please. So when we have a patient of postpartum hemorrhage, then we always go methodically. First, we palpate the uterus. We see whether there's a atony or not. On abdominal palpation, if we feel that the uterus is well retracted, well contracted, then we'll go for either tears or trauma or retained tissue. The most common thing is poor uterine tone. And many times we know what can be the cause of PPH. If you have applied forceps, if you have applied vacuum, and we are suspecting some trauma in the vagina or in the ward in the cervix, and we see that the uterus is very well tonically contracted, then we know we have to look for trauma. But when non-abdominal palpation, if the uterus feels relaxed, boggy and soft, म्हणजे मराठीमध्ये बोलताना आम्ही म्हणतो की ते युटरस असं चपातीसारखं नुसतं पडलंय, दगडासारखं घट्ट झालेलं नाही. त्याचा दगड असला पाहिजे. दगडासारखं जर ते स्टोनी हार्ड युटरस इज अ गुड साइन, whereas a flabby uterus असं चपातीसारखं नुसतं पडलेलं युटरस इज अ व्हेरी डेंजरस साइन. So uterus fundus may not be felt above the umbilicus if the uterine cavity is filled with blood and clots. त्यामुळे युटरस कधी कधी uterine height वाढल्यासारखी वाटते, पण वरनं दाबलं की परत blood clots सगळे बाहेर येतात. So what we do the investigations, since the patient is labor, most of times we have already done our CBC, and I at least have a policy to cross match 1 unit of blood for every patient in labor. Even our hemoglobin is 13 or something like that, I always cross match 1 unit of blood for every patient in labor. So we know, because PPH is going to hit like a bolt from the blue. You never know when it is going to occur for which patient. We know that there are high risks for PPH, but still 50% of PPH cases are those who have no risk factor for PPH. On immunohistochemistry, we do blood count, coagulation profile, electrolytes, and urea, abdominal ultrasound if necessary and if available, because it is very difficult to have an abdominal ultrasound in the room itself. And if the patient is in PPH, we hardly have any time. We have to treat everything in less than 10 to 15 minutes. So shifting the ultrasound motion from somewhere else to labor room and trying to do ultrasound would not be a good idea. We should opt for it only when we are suspecting intra-abdominal bleed, like cesarean section, scar rupture, or post-vaginal delivery. If you're doing a VBAC, there is vaginal delivery after cesarean section, and then you're suspecting intra-abdominal bleed, then only abdominal ultrasound would be of importance, or if you're suspecting a intraperitoneal hematoma. On the management part, we know we go with all the things. What we have to do is there is an algorithm, simply thing. You put into wide bore cannulas, start IV fluids. If we have not done the active management of third stage of labor, which we all do, we have been all taught since ages together, though the drugs have changed, but the approach is same. Long time ago, somewhere around till 2005, 2010, we were using methylergometrin for active management of third stage of labor. Now the drug has changed. Now we either use oxytocin or we can use carbetocin also. So active management of third stage of labor is done. Now, why there was rationale for development of carbetocin in new heat stable formula? We know, though now the days are good and we get electricity 24 hours available, but still that may not be the case in rural areas, in some parts of backward parts of India where the electricity 24 hours may not be available. So the biggest problem is to store the medicines at the temperature which is around, we need around 4 to 8 degrees temperature. So whatever oxytocics we had got previously, oxytocin was to be stored in refrigerator, methylergometrin, sometimes it would do. Then prostaglandin was also there, which was to be stored at room temperature, at the temperature 2 to 8 degrees. We know in summer season in India, the temperature may goes beyond 40 degrees. Sometimes it may go up to 45 degrees. So there is always a need for refrigeration, and the refrigerator needs 24 hours electricity, which was a rarity maybe 10 years ago, not now though. So we need the drugs which are heat stable, because if the drug is not going to act, or it gets denatured at high temperatures, then it is not going to act when you need it. So the rationale for developing heat stable formula for carbetocin was because argotocin and oxytocin needed refrigeration, and heat stable formulation of oxytocin is still not available. Previous formulation of carbetocin was to be stored at 2 to 8 degrees, and the resource poor countries do not always have the cold chain transport and storage capabilities. So now this new formulation, the new heat stable carbetocin, is stable at room temperature, has a shelf life of around 24 months at 30 degrees and 75% humidity, avoids need for the cold chain storage and logistics, and is provided in the single wire. So it is helpful. You can give it immediately, and if it is heat stable formulation, you know that the bioavailability of the drug is going to be there and the drug is going to act when it is necessary. Next, please. So what are the uses of uterotonic agents? We know what are the uterotonic agents which are available to us is either oxytocin, which is molecule which has got a short life, so we have to put it in a drip. Carbetocin is a newer molecule. We had age-old methylergometrin, which was very good drug, and even today it can be used to treat PPH, though it is not now included under the drugs for active management of third stage of labor. Then they had a formulation of combination of oxytocin plus methylergometrin, and we have tablet misoprostol, and I think they have missed carboprost, that is injection carboprost, injectable prostaglandin. So uterotonic agent, when should be administered? There are different times when it should be administered. One is at the crowning of the baby's head or at the delivery of the anterior shoulder. That is the active management of third stage of labor. The intention being that after the baby, the drug also acts as the placenta comes in a single go and there is no bleeding. At the end of the second stage of labor, that is when the baby is delivered completely, or following the delivery of the placenta. Once the placenta is delivered, we need the uterus to contract immediately. So prophylactic use is prevention of PPH, and that is active management of third stage of labor, and therapeutic use is management of PPH. So uterus tonic agent is required and used whenever you need the uterus to retract and contract. Next, please. So this is the molecular structure. We go to the age-old biochemistry where we see that oxytocin is a molecule, and they substitute few things. Substitute with the hydrogen atom and with the CH2 molecule, and substitution with methyl ether group, so that these structural changes, what they did was they prolonged the half-life of the medicine, because we know oxytocin is a very short half-life, and it reduces the enzymatic degradation. So half-life is increased, enzymatic degradation is less. So the drugs keeps on acting for long time. This drug is synthetic long-acting and analog of oxytocin. So it is not natural product, synthetic analog. It has a therapeutic indication of prevention of postpartum hemorrhage due to uterine atony. And the posology and administration is that 1 vial contains 100 microgram of carbetocin in 1 ml of solution for injection, which we give IV diluted. So these are the differences in between oxytocin and heat stable carbetocin. They have enumerated them. So we know that since the drug is newer in the market, we need to know what are the extra benefits of having that drug. So there are 4 or 5 things when clinical indication. There is a reduction of labor. Oxytocin can be used, but no, carbetocin is not meant for induction of labor. Carbetocin is meant for treatment of PPH only. Augmentation of labor also, carbetocin is not to be used, because in augmentation of labor, we know that we have to titrate the dose of the oxytocin, and we have to either increase it or decrease it or stop it. Now, carbetocin, since it has a long half-life, once it is given, you cannot stop it. So augmentation of labor, carbetocin is not indicated. Prevention of PPH. Yes, in prevention of PPH, oxytocin can be used, otherwise carbetocin can be used. That is in cases of active management of 3rd stage of labor. That when the placenta is going to deliver, give it prior to delivery of placenta or even after delivery of placenta for prevention of PPH. Now, treatment of PPH, yes, oxytocin can be given as a 20 units IV drip, we all give. Whereas carbetocin, they have said it is not meant for treatment of PPH, but it is for active management of 3rd stage of labor, that is prevention of PPH. For treatment of PPH, we have oxytocin, we can use misoprostol, we can use methyl argometrin also. Next, please. Now, this is a WHO champion trial, 1/2, where champion was named as Carbetocin hemorrhage prevention, the largest clinical trial in prevention of PPH, where they used carbetocin in few patients and oxytocin in few patients. And this was conducted by WHO Department of Reproductive Health and Research. So the study design was non-inferiority double-blind randomized trial. Now, these statisticians are very good at jingling with the words. So no offense intended to any pharmaceutical industry or pharmaceutical company. They are there to market their products, but they have never said that carbetocin is superior to oxytocin. They have used the word non-inferior to oxytocin. So the objective was to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in prevention of PPH after vaginal birth. So this drug, oxytocin, was compared with carbetocin, and it was compared for a specific thing, that is prevention of PPH after vaginal birth. That is, they have used it for active management of 3rd stage of labor after vaginal birth only. Almost 30,000 women across 10 countries, including India, had enrolled, and the proportion of women with blood loss of at least 500 ml and the use of additional uterotonic agents was measured, and the proportion of women with blood loss of at least 1,000 ml was noted. So these drugs were used in both the patients. And in spite of using this drug, that is, in spite of having active management of 3rd stage of labor, if still the patient bled, then you have to go for more oxytocin or methyl argometrin or something like that. These cases outcomes were compared. Next, please. So when these all patients were given, this is slide 2, blood loss of 500 ml or more, or the use of additional uterotonic. For carbetocin, it was required in 15% of cases, and oxytocin same. So almost similar. The another parameter which was measured by the, in spite of giving these medicines, if there was more than 1,000 ml of blood loss, same, it was around 1.5%. It is almost same for oxytocin, carbetocin. And about safety, at least one unanticipated adverse effect. It was noted about 4.9% in carbetocin and 4.7% in oxytocin. So almost same. And at least one serious adverse effect, which was also similar. So frequency of expected adverse effects did not differ significantly between the two groups. The frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus oxytocin. And the use of additional uterotonic agents, interventions to stop bleeding, and adverse effects did not significantly differ between the two groups. So the conclusion was carbetocin was non-inferior to oxytocin for prevention of blood loss at least 500 ml and the use of additional uterotonic agents. Next, please. So this is a Cochrane review. Now, this is the final word. Cochrane review, they go through all multicentric trials and all many studies and they do the statistical job. So the Cochrane review data from 11 studies involving 2,635 women, they say the author concluded that for women who undergo cesarean section. So this is about cesarean section. Now, in the last slide, we saw about normal delivery. Now, this is about cesarean section. Carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin. Symptometrin is oxytocin plus argometrin. In prevention of PPH for women who have vaginal deliveries and associated with significantly fewer side effects. Next, please. So, guidelines and recommendations are the various societies' guidelines recognize the benefits of carbetocin for preventing uterine atony. WHO has included carbetocin as one of the drugs in guidelines for PPH prophylaxis. Now, PPH prophylaxis is nothing but active management of third stage of labor, which we all learn and which we teach to our students and our housemen and our staff. And we learn that in Manyata programs and NAH programs. That is to give a uterotonic agent immediately after the head is crowned or immediately after the delivery of the baby. So in that, oxytocin came as number one, carbetocin came as number two, misoprostol was also advised. Even methyl argometrin also has been advised. We have been used for so many years, but now it's come down to number four because of a little adverse side effects. We know that methyl argometrin cannot be given in cases of pregnancy-induced hypertension and cases of severe anemia in patients who have a compromised heart. So WHO in long back in 2018 advocated carbetocin. The Society of Gynec Consultants in Canada has for PPH process they have advocated carbetocin. In New Zealand Society, they have advocated active management of third stage of labor by using prophylactic uterotonics. FIGO, carbetocin is one of the recommendations for PPH management. In Germany, Austria, and Swiss bodies, carbetocin 1000 micrograms given slowly. FCOG France, again carbetocin on proving non-inferior to oxytocin actually in champion trial. Expert group of 4 and all this. So my experience with carbetocin, the smarter, superior, and safer choice in PPH management is that first thing I would like to declare that there are no personal interests invested in carbetocin. I don't have any shares of Hetero Healthcare. I have not been prodded by anything by Hetero Healthcare, but simply having about carbetocin, the severe in the PPH. I would like to say that carbetocin, yes, it is a new ड्रग इन आवर आर्मामेंटेरियम. म्हणजे आपल्या भारतातला एक बाण वाढलेला आहे. पीपीएच मॅनेज करताना असताना आपल्याला बहुआयामी नेहमीच बऱ्याच गोष्टी वापरल्या जातात. त्याचा टीम अप्रोच असतो. त्याच्यामध्ये जी औषधांची आपली यादी असते त्या औषधा यादीत हे एक औषध वाढलेले आणि ते निश्चित एक खूप सुंदर शस्त्र आहे पीपीएच मॅनेज करण्यासाठीचं. त्याच्यामध्ये आय हॅव युज्ड इट फॉर normal deliveries. I have it for cesarean section. I have found it to be quite effective. Yes. Are there any questions?
No, sir. We'll come to the panel questions.
Okay.
First line drug म्हणून कसं वाटतं तुम्हाला carbetocin in prevention of PPH?
Yeah. As a first line of drug, carbetocin for prevention of PPH, that is active management of third stage of labor. At present, I am using it 100% for all patients of cesarean section. As soon as I take the incision on the uterus, I'm a little fast at doing cesarean section. My anesthetist pushes carbetocin slowly IV, and I see that as soon as the baby comes out, and I clamp the cord around delayed clamping, I do it around after 60 to 90 seconds, and by that time the placenta is separated. Okay. So this definitely happens only with carbetocin. I've been practicing for last almost maybe 30 years. And I have done approximately maybe 10,000 cesarean sections. So previously, when we used to use either methyl argometrin or oxytocin for active management of third stage of labor on cesarean section, I have found it carbetocin is wonderful because even methyl argometrin, it never used to happen. They used to retract. The placenta used to come and shown after some time.
Correct.
But as soon as you give carbetocin, within no time it acts. And as the baby comes, the placenta follows immediately. Because otherwise, we were always being told, and we have been doing that, the placental separation time at times may go up to 20 minutes. Sometimes it takes 3 minutes, 5 minutes, 10 minutes, something like that. And many of our fellow practitioners who are always in a hurry, they take out the baby, they do the delayed clamping of the cord, and they're not ready to wait for the placenta to come. त्यावेळेस आपले हात असे शिवशिवत असतात, पटकन काहीतरी करावं. And I have found a few people doing, which is a very wrong thing to do. पण मी पण काही काही चुकीच्या गोष्टी करतो. प्रत्येक काही सर्वज्ञ नसतो. ते पटकन हात घालून प्लासेंटा आतून बाहेर काढतात. That should not be done. Now, for those people who are very impulsive and who want that placenta to come out immediately, then this thing can be done, because carbetocin gives no time for you to put the hand in the uterus and take out the placenta. Carbetocin itself pushes out the placenta and it comes out immediately, and definitely that reduces the amount of blood loss. Secondly, for active management of third stage of labor, I still been using oxytocin, because many times I'm not there to conduct the labor. The juniors and the nursing staff conduct the labor, and we have been teaching them the Manyata program and NABH program, and the Manyata guidelines by Government of India and Foxy still have oxytocin 10 units intramuscular after the delivery of the baby. So they are more used with it, but they also saying, sir, तुम्ही सिझरला carbetocin वापरता, मग आम्हाला पण carbetocin वापरू द्यात म्हणून. I'm thinking of changing it. Maybe over the time I will shift to it.
Correct.
The only thing which is little worry is about the cost involved.
Correct.
Carbetocin costs around 400 rupees, whereas oxytocin may cost you around 100 rupees.
Correct.
So it's 300 rupees. So where cost matters, you can think of oxytocin, but still very few places it can matter. It matters. मुंबईत नाही फरक पडत. मुंबईत 1 लाखाची डिलिव्हरी 400 रुपयाचा फरक पडत नाही. पण माझ्याकडे 5,000 रुपयाची डिलिव्हरी 300 रुपयाचा फरक महत्वाचा असतो. So where cost matters, definitely.
PPH you can anticipate in any patient, but generally कुठच्या पेशंटला जास्ती पॉसिबल आहे?
PPH आहे. आता हे सगळं शिकून आता आम्ही सगळे म्हातारे झालो, शिकूनही म्हातारे झालो. PPH, येस, देर आर हाय रिस्क पेशंट्स ज्यांच्यामध्ये पोस्टपार्टम हिमरेज अपेक्षित आहे. परंतु तरी सुद्धा गव्हर्नमेंट गाईडलाईन्स, मान्यता गाईडलाईन्स, इंटरनॅशनल गाईडलाईन्स काय सांगतात की तुम्ही एखाद्या पेशंटमध्ये PPH अँटिसिपेट करणार आहात, तरी सुद्धा प्रत्येक पेशंटला PPH होऊ शकतं. म्हणून तर आपण ऍक्टिव्ह मॅनेजमेंट ऑफ थर्ड स्टेज ऑफ लेबर करतोय ना. ऍक्टिव्ह मॅनेजमेंट करायची गरजच नव्हती. But still, you have to be more alert on the alert mode. Your antennas on when it is polyhydramnios, twins patient, prolonged labor, obstructed labor, infected patients, prolonged PROM, big babies, difficult vaginal deliveries. ज्या ठिकाणी युट्रस खूप स्ट्रेच होणार आहे, युट्रस दमलंय कॉन्ट्रॅक्ट होऊन, आता मी नाही जा बास असं म्हणतोय, अशा वेळेस यू आर गोइंग टू गेट मोर चान्स ऑफ हॅविंग PPH. So you have to be on alert mode. But the wise man's word would be, every patient is likely to undergo PPH, so be prepared for every
expect the unexpected म्हणतात तसे.
कारण it is statistically proven that 50% of cases of PPH have no high risk factor for PPH.
मी सांगतो माझा अनुभव. दिस इज लेट 70s. वन पेशंट वॉज, आय एम टॉकिंग अबाउट JJ हॉस्पिटल मुंबईतलं. वन पेशंट वॉज डिलिव्हरिंग नॉर्मली, अगदी म्हणजे काहीच हे झालं नाही. डिलिव्हरी झाली, एव्हरीथिंग वॉज अँड शी लँडेड इन PPH. दॅट टाइम वी हॅड ओनली 2 drugs, ऑक्सिटोसिन अँड मिथाइल एर्गोमेट्रिन. माय गॉड, वी वर अबाउट टू टेक द पेशंट टू द थिएटर, बट देन थिंग्स सेटल डाउन. बाय गॉड्स ग्रेस शी वॉज सेव्ड. पण तसंच एक्सपेक्ट द अनएक्सपेक्टेड. सो RH निगेटिव्ह मध्ये एनी एक्सपिरियन्स सर?
RH negative carbetocin can be used. I don't think there should be any restriction. But the thing is, what we have been taught that generally we avoid methyl ergometrin, because uteroplastical hemorrhage and more amount of blood going to the maternal circulation.
Yes.
These are theoretical possibilities, but on practical points, I never found any differences. So maybe on the wiser side, if you are suspecting a high risk patient for PPH, maybe you can give it. If you're not suspecting, placenta बाहेर आल्यानंतर मग. So that is the way you can avoid
fetal. Very wise. Yeah, correct. Practical approach होईल ना तू.
कारण काय, ती PPH नी बाई मेल्यानंतर मग RH निगेटिव्ह देण्यात काय गंमत आहे? ती जिवंत राहिली तर त्याच्या मेल्याचं काय करायचं?
You once already answered this. You generally prefer IV route said ना sir?
IV.
कुठे IM ला कुठे स्कोप असेल एस्पेशली आय एम आस्किंग बिकॉज ऑफ द बेनिफिट ऑफ पीपल प्रॅक्टिसिंग पेरिफेरी वेअर IV सेटअप मे बी डिफिकल्ट किंवा
नाही सर, आता पेरिफेरी मध्ये कुठेही असलं तरी अगदी
IV
500
सेटअप.
लोक असतील तरी आयव्ही लावता येणारा माणूस उपलब्ध आहे.
मग
त्यामुळे आता
IM ला
ते
असं काही
पेरिफेरल
खास काय स्कोप
कॅव्हिटीज
नाहीये.
नाही फारसं म्हणजे ठीक आहे. पूर्वी सुद्धा इव्हन डब्ल्यूची त्यासाठीच रेकमेंड करत होती की इंट्रामस्क्युलर द्या. खरं तर तुम्हाला सांगायला आश्चर्य वाटेल, पण जगातल्या कुठल्याही गाईडलाईन्स ज्या आहेत ना त्याच्यामध्ये डिलिव्हरी होणाऱ्या पेशंटला आयव्ही लावा असं कुठंही लिहिलेलं नाही.
बरोबर आहे.
कुठंच लिहिलेलं नाही.
बरोबर आहे.
आयव्ही लावा असं कुठंच लिहिलेलं नाही.
आपला एक्सपिरियन्स आहे हा.
बट स्टील वी ऑन द सेफर साईड आयव्ही लावलंच पाहिजे.
फास्टर ऑनसेट ऑफ ऍक्शन होते ना शेवटला. वापरायचं असल्याला फास्टर ऑनसेट ऑफ ऍक्शन घेऊन. And how it is tolerated?
Carbetocin was very well tolerated. I didn't find any much adverse effects because methyl argometrin, we know once you push methyl argometrin, within 2 or 3 minutes, patient is going to vomit. And we say, okay, the methargin is acted now. The patient ulti झालं तर आम्हाला शंका आहे दुसरं काही दिलं का काय म्हणून. So it was that thing. But overall, Carbetocin was tolerated very well. I don't remember any severe adverse effect after giving Carbetocin.
And suppose एक सिच्युएशन आहे कार्बेटोसिन डझंट वर्क, दुसरे कुठची तुमची इन ऑर्डर ऑफ प्रेफरन्स का यू कॅन यूज एनिथिंग?
Basically, Carbetocin we are not giving for management of PPH. We are giving for active management of third stage of labor. मग active management of third stage of labor नंतर जर atonic PPH होत असेल, then you have to go either for methyl argometrin. You start a drip of 20 units oxytocin. At the same time, you can put in 2 or 4 tablets in the rectum. त्यामुळं ते त्यावेळेस इतका वेळ नसतो की मग कुठं जायचं काय
सगळंच
दनादन यू हॅव टू
इन्क्लुडिंग ट्रान्झॅक्शनिक ऍसिड.
Tranexamic acid, yes, it has been given in the books, and they say that you should be given tranexamic acid prior to delivery of the baby. Correct. So as the blood loss can be prevented or maybe reduced. There are certain trials also, but personally, I'm not using much of tranexamic acid because its action mode of action is different. It is not a uterotonic drug. No. It is going to help in coagulation of the blood. Correct. And I really wonder whether it acts or not. But yes, there are trials. It has been mentioned in the books that 1 gram of tranexamic acid given around maybe 15 minutes or 20 minutes before cesarean section definitely reduces the blood loss. But I don't have much of experience with it.
Advantage तुम्ही सांगितलेलं आहे. Should it be kept as a reserve drug or a first line?
Basically, one thing we have to remember that it is not for the management of PPH.
Yes, active.
Because many times people confuse
prophylaxis.
It is for prophylaxis. If you are given oxytocin as a prophylactic management of drug, and once the baby delivers, then you don't have any reserve drug. You have to do management of PPH.
Correct.
That time Carbetocin is not going to act. So if you want to use Carbetocin, you have to use it as a first line drug only. It cannot be reserved drug. Maybe if it is the cost factor, then only this can be kept reserved for the people who can afford. Yes. Oxytocin can be used for people who cannot afford. Only thing, yes. But there is no other reason for it as a reserve drug because this is not for management of PPH. This is for prophylaxis. So when it is prophylaxis, it cannot be reserve drug. You have to use it again.
It has to be used unless cost is a hindrance.
I think you should be taking this question out of the panel question. This question itself is wrong.
I will take it out. We'll take it out.
Yes. Or maybe reserve only for those people who can
affordability.
बाकी काय रिझर्व ड्रग असं मॅनेज करा. तुम्ही वापरला ऍक्टिव्ह मॅनेजमेंटला ब्लिडिंग सुरू झालं मग तुम्हाला मॅनेजमेंट ऑफ पीपीएचच करायची नाही त्यावेळेस करायचं.
And sir, your overall take home message for the audience?
Yeah, overall experience is quite nice. I've been using it for a long time, maybe year or two for cesarean section. As I told you, my experience was very wonderful. As soon as the drug goes in, the placenta comes in your hand. You need not remove the placenta or need not wait for the placenta to separate. Placenta separates immediately. The uterus goes very nicely. It contracts very nicely. Maybe 1 or 2 patients I had that in spite of Carbetocin, the uterus did not retract well. So I had to use the additional drugs like methyl argometrin, or in 1 or 2 cases, I had to go for surgical things like doing a B-link suture, or I'm fond of doing Cho stitch, mattress suture, something like that. But overall, it is a good drug, nice drug. It can be used. I hope that it comes down in cost within neck to neck with oxytocin. Then maybe it may replace oxytocin. because it has much more things.
Yes.
But think it's a good drug. It is not only me too drug, like every 2 years some new analyst comes into market, and every 2 years a new progesterone comes into market, and we are treating with progesterone pregnancy since in 1960s and 70s, and we still have the same results.
Thank you so much, sir. It was a wonderful webinar to moderate with you. Thank you so much. Thanks all the doctors who took time from their schedule and attended this. Thanks for doctor for sharing your experience, and thanks sales marketing team of Hitro, and thanks IT team for your support. Sir, you can log off. Wish you a very pleasant evening. See you soon, sir.
Thank you. Thank you,
Thank you very
Etro.
much.
Thank you, Dr. Prashant. It was
Thank
nice
you.
interacting with you.
Bhuvan, thank you very much.
Thank you, sir.
Yeah.
Thank
Bye, sir.